Welcome to our Adult Ask the Mito Doc panel. I want to give you a little groundwork about what's going to happen today. It's maybe a little different if you were in the pediatric session, the way we're going to be working with the doctors. We have Dr. Frye, who's going to answer all questions. The other questions he'll be doing, he'll be saying, and Dr. Scaglia, Dr. Gropman, Dr. Koenig that will be doing both, answering verbally and answering the Q&A on the Zoom meeting. I have questions that I will be posing to the group that were pre-submitted by our families, and we will also be accepting questions live from the group that's in the room. So without further ado, I want to get started. I will use one of the questions that was pre-submitted for our first go round. There are our faces. Dr. Haas will be here in a minute. So question number one, and I'm going to actually, this is an important question. I'm going to ask all of you to give your 2 cents on this verbally. Are there any treatments, therapies, or recommendations to help alleviate fatigue?
Yeah, so fatigue is a very common problem in mitochondrial disease, especially in adults. But we see it in kids too. Kids have boundless energy just by nature. There's not any specific therapy that's been designed necessarily for adults. There are some things, however, that do help. There's a variety of different supplements that people try depending on what their fatigue symptoms are. Some people will recommend using CoQ10. Some people will use things like creatine. In some of our patients, we recommend performing a sleep study because if you're not sleeping well, that can contribute to fatigue. So inevitably, everybody gets a sleep study. We also make sure that there's no comorbidities like sleep or malnutrition. Those sorts of things contribute very significantly to fatigue. In a few circumstances, we do resort to stimulants, stimulant medications, things like Provigil or Nuvigil that can wake you up and make you not as fatigued. So if you're looking at something that is specifically targeting fatigue, really the only medicine that I'm aware of would be a stimulant like Provigil, which is used for patients with narcolepsy. It is notoriously very difficult to get approved by insurance companies, and it is not cheap. So the first thing to do is look and make sure there's not something that's comorbid or something else that's causing the fatigue, correct anything that could be contributing, and then talk with your doctor. And the last thing I'll say is don't forget to exercise, because exercise improves everybody's fatigue.
Thank you so much. And I think, yeah, as Dr. Koenig stated, we would usually focus on other conditions like the comorbidities that were mentioned before. But in addition, we have seen, so in certain conditions, I mean, if the patient has anemia, so make sure that actually there's like no anemia, because obviously that can cause fatigue. We have actually encountered that more in children than in adults with mitochondrial disease, because they have Pearson syndrome and Barth syndrome. The other issue has been checking some, hormones like thyroid hormone. We have had cases where there was like low thyroid hormone and hypothyroidism, and of course that created issues with fatigue. And then, as it was mentioned before, checking the nutrition status and making sure that they move, because if they become more sedentary, then the fatigue is going to be worse. And yes, we also try to modafinil. I have experience, colleagues who are like in hematology, oncology, and they were using like modafinil, Provigil for folks who actually have undergone chemotherapy, radiation therapy, but it was like very difficult to get it approved. So in reality, I cannot say of any of the adult patients who might follow who are on that, but I do know that it could help.
Hi, I'm getting feedback. Hold on. So similar to what my colleagues have said, we borrow from our adult neurology colleagues who are using Provigil for Parkinson's disease, for example. And I think I just want to continue to stress the importance of looking for comorbidities, or in other words, other causes of fatigue and not just necessarily assume that all of the fatigue is from the mitochondrial disorder. So I don't know if you guys heard Dr. Tarnopolsky's talk. So vitamin deficiencies, right? Especially if patients are on a restrictive diet or a self-selected diet, really important to go through. I'm a big proponent of going through the diet history every visit and also the supplements that people are on and making sure that there's not another reason that is indeed treatable, because we don't want to miss that.
Yeah, great question. I think people have pretty much covered most of the areas. I think one of the important parts, I think, as we first heard, it's really important is the lifestyle and sleep. You know, not just sleep apnea, but sleep efficiency, getting a good night's sleep, getting a regular sleep cycle is really good. Decreased stress. Stress a lot of times can really cause a lot of problems with sleep. Seems like fatigue, of course. You know, depression is also very comorbid with mitochondrial disorders and chronic disease. So you also have to make sure that there's no components of depression on top of everything else that we heard.
Thank you, Dr. Frye. I think I'm going to move on to our next question. Well, that's not the one. The next one that I thought was really interesting, because this is one I've heard before, is for adults, is it common for Cpeo patients to develop severe psychological problems like severe OCD due to insufficient mitochondria in the brain? And really, I guess the overarching question would be, you know, how common is it for us to see, you know, mental health problems that people need to address? Dr. Koenig?
I actually just answered a question online about mental health and mitochondrial disease. So, you know, just the very most simple start of this question is that people with mitochondrial disease and caregivers of people with mitochondrial disease are dealing with chronic medical conditions, and your life has changed dramatically in a way that most people don't see as positive. I can't believe that everyone doesn't have mental health concerns. It is normal, expected, and okay to have those feelings and those concerns. And so I tell my patients all the time, everyone should see a therapist. Everyone should have someone to talk to. I'd be surprised if you were taking this well and not struggling with how am I supposed to deal with this now. But in saying that, a lot of people with various types of mitochondrial disease are more susceptible to some of the more severe or serious forms of mental health disease, bipolar disorder, psychosis, and you know, manic episodes, things that can be more detrimental or more difficult to manage and do require medical management. So was that the question?
Yeah, the question was basically, is this something that kind of goes along? They asked about Cpeo specifically, but I think the general answer is more helpful.
Yes.
For the community at large.
So the short answer is yes. It is more common. We actually work with a psychiatrist, and we've been looking at markers in the blood in MELAS patients and neurologic symptoms and psychiatric symptoms at our institution. So hopefully there'll be a lot more published on this in the future. But for now, please know that yes, I mean, this is something that, one, from just a logical standpoint, we would expect patients to have mental health issues, but two, mental health concerns is a neurologic disorder. It comes from imbalances in the way that your brain functions and the way that neurotransmitters are passed or functioning in your brain. And if parts of your brain are not functioning properly, then yes, mental health concerns will arise.
Do any of our other panelists have anything to add on that?
I think, as Dr. Koenig stated, I would say that yes, mental. So there are different factors. We've seen, and I've seen mental health conditions associated with in adult patients with like Pol G related disorders. We've seen it also, bipolar disorder in patients, in adult patients with MILAS. And in addition, I think that, receiving those news, coping with the disease, I think that actually adds another factor of distress. So really, when I talk to the patients and their families, we will usually talk about seeking psychological counseling. So very important.
I think my colleagues covered what I was going to say.
Yeah, I think the thing to also remember about mental disease and whether or not it's more common in some of the mitochondrial diseases, that anytime, you can have two different things, and you can be predisposed to have OCD, depression, other things. And psychiatric disorders always get worse when you have stress, and that can be both, medical stress and psychological stress. And whenever you have chronic medical conditions, you have both of those. You have the stress on the body physiologically, and then also the stress from needing to go to appointments, take care of yourself, and such. So it may, even if it's not comorbid with the condition, specifically, definitely having a mitochondrial disease can worsen the severity of any type of mental health condition.
Dr. Haas, do you have comments?
Yeah, I think I would add a couple of things that I don't think have been mentioned. Although it's really difficult to do, the best therapy we have at the moment for mitochondrial disease is exercise. And I think an exercise protocol is something that everybody should really try to do, whether you have mitochondrial disease or not, but particularly if you have mitochondrial muscle symptoms. So the second thing is to make sure that you're sleeping okay, because another thing that happens is sleep apnea. And if there's any evidence that you're stopping breathing in your sleep or you're snoring a lot, then that should probably be checked for. And some of us actually do that routinely anyway. So that's another way of getting really fatigued in the daytime.
Thank you. I want to see if there are any specific questions in the audience. Oh, are there any specific questions in the audience? Doesn't have to be about that topic. It can be about any topic.
Hi, I asked this question this morning. My daughter is 18. We have to look at starting to adult healthcare transition. She has variants of, unknown significance. And so we're finally getting in to see geneticists this summer. But as she starts going into adult care, she's a long-term TPN user. She's been on it for 8 years already. She has all of the symptoms that you all just talked about. She's been on modafinil since she was 13. She's been on Lyrica since she was 15. I mean, we can go on and on with meds that have tried to help her so she could manage her day. But what from your standpoint is going to be the problem of transitioning with a mitochondrial disease from pediatrics to adult care? Because in pediatrics, we have a medical home. In adult care, there really isn't such a thing. And so what happens to all of the specialists that she needs that look at an adult with long-term TPN use? I mean, it's almost impossible to find a GI that wants to do that. How do we find a primary care doctor that's going to want to be a medical home for an adult? Those type of things. And where do you all come in as yourself for mitochondrial and genetic specialists with adults? What does that look like for our kids?
I can answer that. Okay. Thanks. Yeah, so that's a really great question. And I will say that's one of the biggest topics that's been floating around, particularly in child neurology lately, is how do we transition our children into adulthood? I will say, as a child neurologist, we're trained in both pediatric and adult neurology. I was very fortunate that I was at a place where I have continued to see adults. And so I'm both an adult and child neurologist. And I think a lot of the mitochondrial specialists feel that way. So most of the children's hospitals or children's medical centers these days have developed places for transition. So these are clinics which are designed to help young adults transition their medical care. They have identified providers who are able to help move from pediatric to adult specialists. Every specialist that treats a child, there is an equal and opposite specialist or similar specialist that treats adults. It's just a matter of finding them. And it is hard because you've grown to trust your pediatric specialists. And so the thought of moving to someone new is terrifying, I am sure. You know, the first place to start would be with your mitochondrial specialist. Finding a children's hospital where they have a transition clinic. They could potentially help you come up with a transition care plan, a summary of her condition. And these are things that there has been a lot of thought lately at the children's hospitals about. So if you are anywhere near one, I would start looking to see if there's a transition clinic that can help you do that.
Yes.
Okay, yeah, so that's a great question and something that all of rare disease specialists are grappling with. And in fact, there are several consortia interested in that, as well as the NIH funding opportunities for looking at transition. I think, you know, some of the main issues that are different between peds and adults are the time of the visits, right? So internists don't spend an hour with a new patient, or most of the ones I know don't. And also the comprehensiveness. So I think as neurologists and geneticists, you know, we tend to look at multiple systems, whereas when you go to an adult specialist, they may only focus on one question at a time. I was told that by my orthopedist, actually. I can only ask one question about one joint, or I had to make another appointment. I said, that's odd. So, you know, that type of environment, and also the ancillary support. So they may not have, you know, genetic counselors or dietitians or psychologists or, you know, other people who might be in your multidisciplinary clinic. I think it would be nice to have adult multidisciplinary clinics, but a lot of times the specialists that you will see will not necessarily be located in the same center, because maybe the person who's the best for GI is in a private practice, whereas somebody who is treating the respiratory is in one medical center. So I think that the care may be dispersed. There is a website called gottransition.com that a lot of groups are trying to get documentations together for that. Our own experience, we have an adult neurologist who right now we're just transitioning kids with epilepsy, but we have been putting out feelers about more complex adolescents and young adults with metabolic disease. So we'll see how that goes.
Yeah, I mean, I have to agree with everything that everybody said. Many times, being a pediatrician, actually in the Phoenix area, there aren't a lot of adult specialists. So I tend to see the adults. They come to the children's hospital and they like it better that way. I think, as Dr. Gropman had said, we spend a lot more time with them, and you know, our nurses are nicer too. So that was a joke. I think that it does require multidisciplinary teams, and these aren't available in all areas. I think this the age right now is very good because we have the ability to use telemedicine, and a lot of doctors are utilizing telemedicine. Sometimes you have to put teams together yourself and find the best people, and the people that you fit with the best. You know, it may not be the best or worst doctor, it may be the person that you really connect with. And I think we have an advantage now by using telemedicine for you to find the team and put together the team that you like and that works together the best, but it does take work.
And finally, I think that I wanted to add that, yeah, I agree with all the other panelists that it's very important to have like a transition team. Thankfully, in the last, it started initially for our patients with what we call inborn errors of metabolism. Well, mitochondrial disorders are inborn errors of metabolism, but we do have a separate metabolic clinic. And within Baylor Clinic, there is a MedPed program, so internal medicine and pediatric program with a transition clinic, because we still are seeing those patients in our pediatric metabolic clinic, but they develop other problems as adults. So and we are doing the same thing now for our mitochondrial patients who are transitioning from the pediatric to our adult mitochondrial clinic. But we try to start, I think that there is consensus that the transition should start earlier at 14 or 15 years of age, and not just wait when the individual just turns 18 and then you said, okay, my gosh, what do I do now with the other specialists that are not very familiar with mitochondrial disease? And as other panelists have mentioned, GI or other specialties, neurology and genetics, we do make exceptions. But so building bridges, obviously, with the adults as specialists has been key to have a sustainable adult mitochondrial clinic.
I want to address Dr. Haas next. I see that there's a Q&A question online that you were interested in answering live.
Yeah, I'm happy to do that, but let me just add a little bit to the discussion on the last point. That it really is a terrible problem. I think one really good move is to find an adult primary care doctor who hopefully is a really good internist as well. And then that can help direct you to the other services that you need. And then from the pediatric side, if, for instance, you're in the pediatric GI clinic, they should know who their adult colleagues are and can make suggestions about who you could be referred to as well. So you should ask for each individual problem that you have, who they suggest. Yeah, so the question here was approximately what percentage of mitochondrial disease patients have respiratory weakness, what percentage use a ventilator, and are respiratory exercises advised? So I don't think we know exactly what percentage of mitochondrial disease patients have respiratory weakness. If the major problem for an adult or an older patient is muscle weakness, then they may well have a respiratory component. And if that gets severe, then they will often need a BiPAP support at night, but they're not really being ventilated. In my experience, it's pretty rare for an adult to need ventilation. But on the pediatric side, we have this terrible condition, Lee's disease, where there's a central respiratory failure. And those patients may wind up on a ventilator and need, lifelong care with a ventilator. And as far as the adults are concerned, respiratory exercises are certainly going to be a good thing to do. If there's any suggestion of respiratory muscle weakness.
Thank you. I'm going to go to one of our pre-submitted questions. This is one I get a lot and don't know how to answer it ever. Is it possible to be an organ and/or tissue donor? If so, how do you donate to mitochondrial disease research? So, do you have any ideas?
I will say that is a very good question, and one that I would say that I do sometimes get asked. I do not know the answer to it. Does anybody else?
Was just about donation or donating to like a biobank, because there are two issues. One would be there is through NAMDEC, through the mitochondrial registry, a repository of tissues, and I think that could be useful for research itself, and eventually it could translate into trials and patient care, although it will not have an immediate effect. Andrea.
Yeah, I don't know of any biobank that's specifically to mitochondrial disease. I wish there was. We have it for a lot of other diseases. And it's probably something that would be a great idea to have.
Thank you. I will say that one of the things that when people call me that I recommend is that that they go to NAMDAC and make sure that they have been are a part of that very important initiative. Okay. Any questions in the audience?
Assuming most of you see pediatric patients and their caregivers, and you're dealing with the caregivers who may or may not carry a gene, how often would you say the caregiving adult that has that same genetic, asymptomatic genetic mutation or what have you, turns into symptomatic? And kind of describe, if you've ever had an experience with that, what that looks like, please.
Yeah, I've seen that several times with my patients and it's not clear, if the moms would have developed the disease anyway, or it's due to also the stress of taking care of the child. But I find that I've had several women at about 35 or 40 start to develop symptoms, particularly of sometimes migraines, ADHD, but also pseudo-obstruction and other severe issues. So I think you have to be on the lookout, and it's good to be proactive if the mother carries the disease, the gene, look out for signs and symptoms, maybe even start treatments if you think that it could be preventative. I know there's limited evidence, but it's something that could be helpful.
I think going back to your question, I guess because you said, could you provide examples? One that comes to my mind is of young adults, that actually have maybe like or I would say like, late adolescents who have like Paul-G related disorders. And then we started noticing that, on their parents, they had, okay, now that seems to be ptosis. Okay, they may have some ocular manifestations because, even with Paul-G, I mean, if there is just like one non-working copy, there could be some issues with like moving the eyes or having like droopy eyelids, and I think that, and perhaps they have that before, but we were focusing on the child, and then we realized, okay, this seems to be now worse. And there are cases that I can recall, families with Milas where there was, seemed to be, eventually we were in contact with a maternal grandmother who actually, came to our clinic, bringing the child, and she had the custody of this particular child, and then she had some cardiac issues, and we found out, we need to test her. She had hypertrophic cardiomyopathy. She seemed to be seemingly unaffected, but of course she hadn't had any extensive cardiac evaluation. So I think that as soon as we see other extended family members, we have to think about that. Okay, well, we need to test them, because they can be at risk, even if.
And a lot of times they should be followed as well.
I am interested in participating in a clinical trial. How do I go about finding one that I actually qualify for?
Thank you for asking this question. So I'm a big proponent of clinical trials. I think the easiest way for a mitochondrial patient is probably to go to the UMDF website. They have a large resource listing the clinical trials that they would potentially be eligible for. I will say that it is very complicated trying to decide if you're eligible for a clinical trial or not. But if you look on the UMDF's website, they will list clinical trials that you might be eligible for. And if you can't tell whether or not you're eligible, there should be an email address there where you can email somebody and say, hey, am I eligible? And let them figure it out. Your job isn't to try to understand all of the eligibility criteria for every study that's out there. That's our job. So email every one of those studies and tell them that you are interested in participating in a study, and they will ask you some basic screening questions that will help determine whether or not you're eligible. And that's my best answer.
Yes, and I think I agree with that. We usually direct families to, or talk to families at UMDF, but then of course, I mean, if they are seeing us, we will do the work for them and try to find the best trial. I think that sometimes families can also, they have been like, very savvy going to like clinicaltrials.gov and then, putting some keywords with the name of the condition and then finding answers. But I think it's important that when they come to clinic, I think it's our job to, tell them the most accurate information. Yeah.
Yeah, I was going to mention clinicaltrials.gov and putting in a keyword. So it's important to note which trials are still open, because depending on what you use as your search engine and which boxes you check off, you may get all trials, including those that are close to accrual or those that are completed or those that aren't yet enrolling, as well as those in foreign countries. So, and again, there'll be a list of eligibility criteria and a contact person and the location where the trial is being conducted.
Yeah, clinicaltrials.gov is a good website, but it can be complicated, as Dr. Gropman says. And what is, you can contact them. They usually have contact information, but also if you have a mitochondrial doc, a lot of times it's best to, compile them and kind of bring it to them and ask them, because they may already know about some of the trials and whether they're open or whether they have specific criteria. Kind of saves time, it saves and reduces confusion.
So I think one thing that you really should do is contact your local mitochondrial center. Now, that's a kind of silly thing to say, because in parts of the country there isn't a local center, but your closest center, and they should be able to tell you. We have clinical trial coordinators at pretty well all of these centers now. They should be able to tell you what trials they have up and running, and whether you might qualify for them. And then you can also find out what other places have. We're a good source of information because we have our finger on the pulse about that.
Yeah, what we do with our clinic, so our neurogenetics clinic, where we see Mito patients and other conditions, is we do the preparatory work where we kind of put all the records together and all the lab results. And so what we'll also do is put a little reminder as to what trials the patients might be eligible for, so we don't forget to discuss it with them. So whether it's the NAMDAC registry or something from clinicaltrials.gov or our center or another center. So that just, gives us a heads up to remind to discuss it with the families.
The next question is going to go to Dr. Koenig. There's a question that you wanted to answer live from the Q&A.
Yes, and I more wanted to hear everyone else's answer, which is why I tagged it for live. So the question is, as an adult, I seem to be progressing quicker as time goes on. How do you know when you shouldn't or can't live alone anymore? And I feel like this is a question that I get a lot from my patients, and I don't think that it's the same for every person. So I know what my opinion is of it, which is why I wanted to bring it out live, because I wanted to kind of see what everybody else's opinion was.
Yeah. I think that this is, we try, so we initially started to have this particular team of palliative care in our pediatric mitochondrial medicine clinic at Texas Children's Hospital. But now we have incorporated that also at the adult mitochondrial clinic. And I think that, these issues of quality of life, when the fear of losing independence and all that, I think that this is something that we have to individualize, for each patient. And also, we are in constant conversation with our adult neurology colleagues, when this person would have to maybe transition to another facility and, not being able to, live by himself or herself. Yeah.
So that's a good point. We also have PT, OT, and physical medicine and rehab do an assessment, like a functional assessment on the patients to see do they have motor issues, or are they able to take care of any or all of their activities of daily living? Would they be able to do that with somebody in the home, or would that even be difficult? What about speech and swallow? Would they be able to, even if they weren't able to prepare the meals, but if meals were brought in safely, eat and swallow without somebody being there? These are important questions.
Of course, it's important to, every situation is going to be different, and it'll be dependent of how many and what type of family support you have, who can actually help you, and if things are progressing quicker, making a plan as for what's going to happen as things progress to different levels, so that you can assure that you're safe. The most important thing is that you're safe in your home or in some type of assisted living or independent living type facility. But you want to make sure that you're safe, that you have the care that you need, so you don't get yourself into trouble.
Yeah, thank you, everyone. I actually really appreciate hearing your thoughts. For me, it comes down to safety and quality of life. I'm also a big proponent of palliative care. I think that getting palliative care involved early is important, because this doesn't mean end of life. It means making sure that you are living your life to the fullest and the best way that you can, in the way that you want to. And that's why I say, for me, it has to do with an individual person. I think that the answer to that question is different for every person. There are some people that it is extremely important for them to maintain their independence, and they are willing to shorten the length of their life to maintain their independence. And there are other people who are not. And those are discussions that you have with a palliative care physician. What sorts of risks are you willing to take in order to maintain what type of lifestyle? Do you want to have a ventilator? Do you not? Maybe it never comes to that. Do you want to have a pacemaker? Do you not? But these are questions that have to be answered, and they have to be informed answers. And that's best done with a physician, and the type of physician who does that is a palliative care physician. And the real decision about being home has to do with what your comfort level is, where your risk level is, and what is considered safe and what is not considered safe, and what risk level you're willing to take to maintain what life you want to live.
Thank you. I think I'm going to move on to the next question, one that Dr. Haas wanted to answer live.
So that's the question, I believe, about being particularly susceptible to COVID. Is that right?
Yes.
And I think across the nation, we've discovered that if our patients are vaccinated and boosted, they're really not any more susceptible to COVID, at least in my experience, than the general population. Obviously, the older you are, the bigger the risk, but most of the mitochondrial patients who've developed COVID have done very well. So that's kind of the good news, I think. We've had a few that have deteriorated after a COVID infection, actually, with pneumonias, pneumonia as a secondary consequence, and then had a metabolic setback. But that's pretty rare. Mostly, we hear that they've had COVID at home and have done fine.
Thank you. I have a pre-submitted question that I want to pose to the group. Can patients who have any of the LH1 mutations experience other mito disease symptoms, such as myopathy?
Yes, so we have, and sometimes, like, depending on the nature of the mutation, we have been able to find among our cohort of patients with LHON, not only visual issues, but also like hearing issues. Some of them with even like mild to moderate, like sensory neural hearing loss. We also had another patient that actually had a cardiac arrhythmia and had to have a laser procedure, like an ablation of a pathway that was actually generating like this this arrhythmia, and some of them had actually experienced fatigue and myopathy. So although, initially, for our adult patients, we focus very much on the eyes, but it could potentially affect other organs.
So there's actually a clinical spectrum of LHON, LHON plus, and LHON MS. And so particularly in women with LHON, the visual issues may not be, at least initially, they may not even have visual issues. So these are women who have been identified because of other individuals with LHON, maybe sons who have, the typical progression of vision loss. So they can have tremors, they can have myopathy, neuropathy, bladder issues. Some can have features that look similar to multiple sclerosis with numbness and dysfunction in various parts of their body. So we're learning more about this spectrum of findings. It tends to be the LHON plus, there tends to be a family history of LHON. There tends to be more males than females in the LHON plus, and then also a later age, above age 22.
Thank you. I am going to see if the audience has any questions. All right, I'll go back to a pre-submitted one. Are supplements or natural sleep aids, focus aids, and pain products okay or safe for Mito patients?
I think, whenever you talk about things that are over the counter, I think you need to be extremely careful because many times the formulations can have certain additives in it that many people with Mito and sometimes, other conditions are very sensitive to. So, and we don't know about the purity of them. So if you were going to use any types of natural sleep aids or any of the over-the-counter type supplements, I would make sure to ask your doctor what the best, what they recommend, if it's a quality product. And then some people are very sensitive to the additives in some of these products. So it might not be the actual aid itself or the component of it, but sometimes the additives. So I think you have to be very careful with these.
Anyone else on the panel have a comment on them? All right, we'll move on to the next pre-submitted one. Oh, here's one. Long COVID and Mito. What do we know? Any comments?
It will be brief. I would say that I don't think that we have any data to share because obviously, we've been learning about COVID for like now 2 years. And now there are even studies, to focus on patients who have like long COVID, but long COVID and mitochondrial disease. I personally, I don't think we have any data. Yeah.
Another pre-submitted question. Is IVIG treatment helpful to prevent neurological regression?
So this is a loaded question, and one that is hotly, I think, discussed or debated. So I'm a neurologist, and IVIG is the magic medicine in every neurologic condition you can imagine. You don't know what it is, you give them IVIG. It's got to be immune mediated. And so, we use it for epilepsy. We can't stop the seizures. We use it for neuropathy. If the patient has neuropathy and you don't know why. And so it's very comfortable, and it's something that's very commonly used in neurology. I don't think anyone knows the answer to that question, though. I think there are some patients with mitochondrial disease who have immune dysfunction, and very clearly those patients should be on some sort of immunologic modulation under the care of an immunologist. I absolutely believe more research needs to be done related to the effects that supplemental IgG have on the brain and neurodegeneration. But I don't think we know the answer to whether or not it has anything to do with preventing neurodegeneration in patients with mitochondrial disease.
I'm not a neurologist, but by collaborating with my colleagues from neurology, and this I have to say, has applied more for like pediatric patients than adult patients. There is this, as you pointed out, this sort of like anecdotal, maybe evidence, could that have helped? I mean, we had one patient that was found to have changes in MTFMT, and we published actually his case. He was 18 and initially thought to have, before the results of exome sequencing, like ADEM, and I thought, oh, maybe IVIG is helping. He was saying, well, initially it helped, then it didn't help anymore. So, I mean, I guess we cannot like rule that out. But again, I can only talk about like anecdotal cases. Yeah. And then I guess regarding IVIG, but this is not connected with neurology, I have followed few children that actually have like clearly documented, obviously, mitochondrial disease and immune deficiency, and they were getting IVIG, but not adults. Yeah.
Yeah, I would agree. So IVIG now is like what steroids was years ago, where if you didn't know what something was and you gave steroids, it made people better, but you didn't necessarily understand why. And it's not always safe. There are some people who might have an IgA deficiency who, they should be tested before they get IVIG, but I know at least one time that wasn't the case and someone had a reaction. So I think a lot of consideration has to go into why you might want to use it and if it would be safe for that patient and what your end result would be. In other words, like what are you measuring in terms of a marker of efficacy?
Yeah, I mean, definitely more research needs to be done where I found it to be most effective in not necessarily neurodegeneration, but I found that kids that have Mito and may have hypogammaglobulinemia and have recurrent infections, that is, they're sensitive to infections, and the infections tend to cause them to get fatigue and worsen their symptoms, and they can kind of get into this vicious cycle where they have an infection, it worsens their mito, they're metabolic, and then they're more sensitive to infections. And I found with some of those kids, not high dose, but even just low dose, IVIG, that was what I was using. Now a lot of people use sub-Q, immunoglobulin, seems to help stop that kind of vicious cycle, and helps them normalize, get more energy, and live a better life.
Yeah, I think those are the kids with immunodeficiency, right? So they should be seeing an immunologist.
Thank you. Do you have any additional comments, Dr. Haas?
Well, we use it in lots of pediatric neurological conditions and adult conditions, but not really in mitochondrial disease. So I don't know of any particular reason, unless, as Dr. Frye says, there's real immunodeficiency. It could be helpful in that situation, perhaps.
All right, thank you. I'm going to move on to the next pre-submitted question. I have Mito, and one of my symptoms is diabetes. It is very hard to control. What can I do?
So notoriously, diabetes is very hard to control, especially in adults with mitochondrial disease. It is the bane of my existence. So for starters, you need to be with an endocrinologist, not a family medicine person. Again and again, my adult mitochondrial patients come into me and they're following with their family physician who is managing their diabetes. So historically, we always talked about type 1 diabetes, which is childhood onset, and type 2 diabetes, which was adult onset. And those are very clearly understood. They're very well defined. The type of diabetes most mitochondrial patients get is different than that. It's not type 1, it's not type 2, and it is much harder to control. Often patients need low oral hypoglycemic agents, like insulin, and they're very prone to hypoglycemic episodes as well. So step number one, you need to be with an endocrinologist. Step number two, that endocrinologist needs to understand that you don't have type 2 diabetes or type 1 diabetes, that you have a mitochondrial disease, and it is a different ball game. And there are some papers that have been published on diabetes and diabetes care in patients with mitochondrial disease, and I would suggest very strongly that they look at them.
All right. Well,
And one thing to that there's a clinical trial coming up by a company, Believer, and they're hopeful that that's going to be a diabetic treatment also. So it may be worth looking into that when it becomes available.
There's also a registry that's coming out looking at diabetes in patients with mitochondrial disease. And gosh, I wish I had more information on it off the top of my head, but I don't. But I will make sure that we get it to the UMDF. And if you do have diabetes that's mitochondrial, I would definitely recommend that you register for that registry because information is power.
thank you so much. We are just a few minutes left. I'm going to look for one more run of questions from the audience and then try to get through my list of pre-submitted questions. This is a big one. This might take the whole time. What is an acquired mitochondrial disease?
It's just an add-on to the mitochondrial. I've been told by a major hospital not to use insulin because my sugar goes up so fast, goes down so fast, but what really happens, and it's been happening here, is I burn apparently muscle, and if I go upstairs and get enough fat from things, you can literally watch me go from actually up to a stroke-like thing, but starting to look at it, and within minutes, 10 minutes, my face, and I will look like I can walk and talk again. But I also go all the way down to 38's the one that I know the most of. And I had a very good doctor who told me to stop listening to everybody because the dietitians wouldn't, and they told me to keep it between 100 and 125 and not let everybody go with the way they're actually treating everybody else.
Well, I think this is exactly what the person who asked the question was experiencing, that just the control of it was so difficult. So onto that acquired question. I do get this one too. People call me and say that they believe they have an acquired mitochondrial disease, and I don't have a lot of resources. Do we have any ideas on things I might share with them, and or any?
I think so.
I think I used to be an advisor, say, geneticist for, this was like an antiretroviral pregnancy registry. And I think that, this is one example that sort of like comes to mind. I mean, there were like patients infected with HIV that were receiving initially, before we have this sort of like combination cocktail of medications, they were receiving AZT or some inhibitors of the virus, so the virus would not replicate, and they were also affecting the replication of mitochondrial DNA. So some of these patients have lactic acidosis, have issues with like myopathy and all that. So that could be an example of sort of like an acquired mitochondrial dysfunction. I don't know if maybe other members of the panel want to add another example.
Yeah, I mean, there's many patients that we have that seem to have biomarkers of mitochondrial dysfunction, or even biopsies that are, look like they may have partial defects in the electron transport chain where we never find the genetic component of it. And the question is whether it's acquired or not. And sometimes we don't know the answer to that.
Oh, thank you. I'm going to go back to my pre-submitted. Oh, this is an interesting question. I have a clinical diagnosis, not genetically confirmed, of mitochondrial myopathy, so I can't currently participate in the clinical trials. If the clinical trial medications are approved by the FDA, will I have access to them?
This is a great question. And this is where I think actually having pediatric experience helps. So I will say, as a pediatric neurologist, a lot of the medications that I use are not approved or indicated for children because it's not always ethical to test things on children. And so the FDA doesn't, if you don't test the drug on a child, then you can't approve it for the child. But it's a drug that's used and it's approved for an adult indication. And we extrapolate that data, we use it in children, and that's called off-label use. So you use it for an indication that's not necessarily what it's been reviewed by the FDA for, but as a doctor, you're allowed to make that clinical judgment. And we can do that for any drug that's been FDA approved, as long as we are doing it safely and we're not violating the medical license and doing something crazy. The problem is getting the insurance company to pay for it. And so the way you can convince an insurance company to pay for it is by having substantial evidence or research or papers that confirm its effectiveness. So if you have a mitochondrial myopathy that is not genetically confirmed, and you have a clinical trial that has been proven to treat mitochondrial myopathy in patients with genetically confirmed mitochondrial disease, it's not a big stretch to say that a drug that is approved for genetically confirmed mitochondrial myopathy will also work for non-genetically confirmed mitochondrial myopathy. I will say that it is very likely that the insurance companies will make every attempt possible to deny it. But there will be one or two cases where it slips through and it gets approved, and then those patients are able to take the medicine. And then there'll be 5 or 10, and then there'll be 100, and there'll be 200. And eventually the evidence will accumulate that it does work for non-genetically confirmed mitochondrial myopathy. And eventually the doctors will have enough proof that it works for that, that the insurance companies will not be able to ethically deny it anymore. So the short answer to that question is that your doctor will be able to prescribe it off label. It's a matter of getting it paid for.
Any other comments on that question?
I think it also depends on where you are in the country and your insurance. So for example, we do a lot of MR spectroscopy at my hospital, but we can't get it improved by insurance. Although my colleague at Mayo uses something I wrote as a fellow a long time ago about spectroscopy in metabolic disorders, and that's a shoo-in for them getting it approved. But I cannot do that in my own paper. So, you know, I think it just depends where you are and the insurance.
Thank you. I think we have a time for just a couple more. Let me see. There's one that I thought was pretty interesting. Oh, sorry. We need you to talk on the mic.
I'm loud, you know.
Mm.
High blood pressure and heart disease. What's your thoughts on that? In terms of Mito, yes.
Is it common in Mito?
So heart disease is common in mitochondrial disease. There's various forms that we see. You can either have cardiomyopathy where the heart doesn't pump as well as it should, or you can have an arrhythmia where the beat is not normal. And either one predisposes you to heart disease. So yes, it's not necessarily treated in a special way. It's just treated by a cardiologist, but we do screen for it frequently, and it is much more common. High blood pressure, I don't necessarily see high blood pressure more commonly in my mitochondrial patients unless they have kidney disease. And kidney disease is more common in people with mitochondrial disease and can sometimes produce high blood pressure.
Yeah, likewise. I think that we haven't seen adults, the only adults that I recall have like elevated high blood pressure. These were adults with MELAS, or I guess they have the common genetic letter change that can cause MELAS, but in their particular case, they presented more with kidney disease. And in fact, I mean, we were considering, renal transplantation because they were a kidney transplantation because they didn't have strokes. They have mostly a renal issue or kidney issue. And then that led to having elevated blood pressure. And as Dr. Koenig said, yeah, the cardiomyopathy, sure. I mean, we see that the cardiomyopathy and, having like an extra beat. I mean, and that's why we, if they have that, of course, they should have, we refer them to cardiology, and then cardiology determines, how often, at least, once a year or perhaps more often, depending on their response to treatment. Yeah.
Yeah, and the other one thing to consider if there is high blood pressure, and of course, kidney disease, heart disease, and any endocrine disease, which, probably should be monitored if you have a mitochondrial specialist.
Yeah, I heard you. So she wants to know how do you find a cardiac specialist in mitochondrial disease or a mitochondrial specialist? The first one. Okay. So the question is, how do you find a mitochondrial cardiac specialist? Let me know when you find one. Mitochondrial physicians, first and foremost, are few and far between, and most of us are not cardiologists. So your best bet is to find a cardiologist who's willing to work with your mitochondrial specialist, but the cardiologic management is typically the same as it is for someone else with a cardiac condition. It's really just that they're able to recognize the increased risk, know what the tips and tricks are, and what the screening frequency needs to be. So how often do they need to be monitoring your heart? And most mitochondrial specialists can tell them that. So for example, I could tell you how often, based on your diagnosis, I don't know you, but if I knew your diagnosis, how often you should have your heart checked, what kinds of testing you should have done. When it comes down to if they identify a problem, they're going to treat that the same way they would treat it in anybody else. So they don't necessarily have to be a specialist in mitochondrial disease.
Dr. Haas? Here she comes.
I think it does help if they've seen other patients, though, because like all subspecialists, if they haven't encountered the disorder, they don't feel all that confident treating it. I'm lucky. I have a particular cardiologist who runs the cardiomyopathy clinic who looks after most of my adult patients. But the other issue, apart from just the heart muscle and the way that it works, is the problem with cardiac conduction, which is sometimes peculiar to mitochondrial disease. For instance, patients with severe Kearns-Sayre syndrome will very often develop heart block. And I find that I really need to lean on the cardiologist to get a pacemaker in those patients. So there are some times when, we can help you find a cardiologist, particularly if you're having acute symptoms.
All right. Any,
I told her and she said, I can tell you this one. I want to see a big change that I think will help a generation of middle school and high school kids. We do a lot of studying here on infant children and diagnosis. I would love to see you get out there something that's beyond me. And that is, if we can get the ER and primary doctors, when they can't figure out why I'm having all these things, and not just me, because I'm married to a doctor and I'm lucky, but all the other women who are walking around being told you're somatic or you have this or you're having panic attacks. But in my history, it includes you have lupus in 1992. No, you do. No, you don't. No, you do. Cardiomyopathy. I've been through 3 cardiac rehab things of it. Actually, I could have done 7 and so forth. And a daughter who has a train wreck, both autoimmune, whatever. But it's more important because not just my daughter, but I know there are hundreds of young adults going, do you want a happy, don't look at your mom. I can give you a happy pill. If you start,
Eileen, I have
wait,
a-
I'm
don't-
almost done.
I want a
10
question. Do you
seconds.
have a question?
Yeah, I do,
Okay.
because here's the question. If we can come up with a way to start pulling out us, quote, old ladies and getting ours 40 and up, that we're not diagnosed, that we have a get out of go and form that they go, oh, actually, you might be mitochondrial. If we test all these and you start getting our genes as, yes, you're Milas or you're CPT2, can you then with that have a prescription to just go, okay, your 6 grandkids, we can check theirs and then have a system to start helping them before middle school, high school, and not have their lives ruined. It's a backwards way than I've seen you doing it, because it's not, the mitochondria adults have not been recognized for most of the time, and you're only starting to. But I'm asking, is there a way that we can start through CMEs or something in the physicians, family practice, geriatric, neurologists, all of them? They need to have a system where they can go, oh, your mother, your aunt, your sister had click, 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 these symptoms of mitochondrial. Oh, we can refer them to mitochondrial to, hopefully we'll get out there the doctors who can recognize.
Well,
and
Eileen,
send
I
it to
understand what
how
you're,
can you-
I
how can
understand
you
what
do
you're
that?
saying. Longer topic than we have to, we'll be able to cover today, but I do think it's important that in terms of when you're in emergency, would you like to talk about any procedures you might need in an emergency if you were in the ER? I think there are protocols that people might have. I think that's one of the questions that I was able to pull out of what Eileen was asking. What should families do in terms of being ready for an emergency situation?
Yeah, I think it's really important for everybody to discuss emergency situations with your physician and to come up with a plan for what to do in that situation. Most of our patients will have what we call a protocol letter or an emergency letter that they carry with them. There's also a variety of different types of medical alert systems that you can use. There's some that you can download on your phone now, where it can have your medical history. You can have a USB drive that you carry and a bracelet that the ERs look for, things like that. You can have a medical alert bracelet that just has a phone number, and then they can call. So they can, for example, you could have someone call your husband or your wife or your daughter to get your medical history and kind of know what to do. But having an action plan is always a good idea.
Yeah, I agree completely. We have, so not only for our pediatric clinic, but for our adult clinic, we do have medical emergency letters that we distribute to our patients. That's also part of our like after visit summary. For example, an adult with Milas and having like a detailed plan that could be presented. I mean, they will still contact us, but the team will be prepared in the emergency room thinking, oh, this person will need arginine. We have also, for that particular issue, been working with like IT teams, Ibig teams in the hospital, not only the pediatric, but the adult hospital. So when the patient comes in and that patient is registered, then the plan of action will sort of like come up. They will still contact genetics and neurology in our case, but yeah.
Yeah, we have similar. So every patient has both an emergency letter as well as a surgical planning letter. So, what to do if the patient needs to have a surgical procedure. Now, we work really closely with our surgeons and anesthesiologists. In fact, we had a patient who needed an ortho procedure who had pyruvate dehydrogenase complex, and literally every hour, the anesthesiologist was texting me about blood sugar levels and glucose, so we could, tweak things and tweak the fluid. So it's really important to have communication. And then I think one thing to address the concern of the person in the back is that when you go to see a geneticist, they take a family history. So if somebody's identified as having a condition, they will typically ask about, we tend to go up and down. So if you're an adult, we will ask about your parents and relatives on that generation, as well as your children and, your siblings and your siblings' children. So getting a comprehensive genetic history or pedigree or family tree is part of the medical history when you go to see a geneticist.
Yeah, I think she made an important point about, and as you did, about getting the history, but also going that extra step and making sure that the grandchildren, the children are not asymptomatic and may manifest or could manifest the disease. We're only starting to do research on treatment of mitochondrial issues, but of course, ultimately it'd be prevention of the disease symptoms manifesting. And there's little research on that, but I think that would be the ultimate way if we were able to figure it out before full symptoms manifest, how we can prevent that from treating early.
Yeah, I want to say one other thing about emergency rooms and emergency protocols, because I know a lot of people here probably don't live in the same city as a mitochondrial center. So it's all good and well if you present to my hospital or Dr. Gropman's or Dr. Scaglia's, but if you're somewhere where you're not, one of the things we tell our families is go to the emergency room with your protocol letter from your doctor when you're not having an emergency. And during a time when it's not a high peak emergency time, like, I don't know, Sunday morning, Tuesday morning at say 9 o'clock. Emergency rooms are pretty empty during those time periods. And take your emergency letter and say, hi, I am a patient that has a rare disease and my doctor suggested that I come here and tell you about my disease in the event that I present with an emergency. And that way they can start a chart for you and have it on file so that if you do come in, they have a little bit of information about you and what to do.